we're delighted to have a significant number of attendees, 119 from institutes in North America, hopefully some from South America, many from Europe, and hopefully some from Asia and Africa. Just a quick point, I'm Jeff Copeland, founding president of IANPHI and currently an emeritus director. We are delighted to have some excellent speakers and people with great experience in this, and it conforms to our initial goal in establishing IANPHI, which was that in times of crisis and in times of need, those of us in national public health institutes, like the two presenting today, can share information, can share the stresses of what goes on in a pandemic or an epidemic, and learn from each other. And that's the goal of today's meeting as well, to share our experience, to hear what others have gone through, and to identify applicable elements of what you've learned in our own work. And that's by our, I say all of us, in the multiple continents, multiple institutions that are represented. Excuse me. Our panelists today, and we'll try to get right into the presentations, and we'll have time, we hope, for nearly 30 minutes of questions and answers. But our presenters today to discuss the exit strategies and how they're putting them into place are Dr. Johanna Hannefeld from the Robert Koch Institute in Berlin. She's scientific director and head of her department in the Center for International Health Protection. And our speaker after Dr. Hannefeld is Dr. Frode Forlund, who's specialist director in the Norwegian Institute of Public Health. So let's start with Dr. Hannefeld and get right into the information. Dr. Hannefeld.
Okay. Thank you very much for the introduction. I'm delighted to be able to share a little bit some of our thinking around COVID exit strategies. Can I just check that you can see my screen now?
Yes, looks good.
Okay, excellent. So I'll present a little bit some of the sort of ideas that we have been discussing in Germany in relation to de-escalating some of the measures. But before I do that, I wanted to, apologies, I have trouble now getting the next slide up. Apologies. I wanted to spend 2 words just to talk about our epidemic in Germany. So we had, we've to date had about 170,000 cases of COVID. We have a national incidence of about 200 cases per 100,000, but we are still cautiously optimistic, but we are sort of at the tail end of our first wave, and we have had a couple of things that I think are important or were important to us in thinking about the when we think about de-escalation or managing the new normal with COVID. So one is that we are a relatively big country. I mean, I don't know whether to say it, but we're a population of around 80 million, and we've had a great regional variation. So we're a federal system with some states much more affected, consistently much more affected than others, even though we have cases of COVID all right across the Republic. So here are some of the figures, and there's also some information for up-to-date figures if people are interested. In terms of COVID, we had a very initial cluster at the end of January, and then we really saw a much more rapid rise at the beginning of March. And
Johanna, excuse me for a second.
Yeah.
I think you expect to have slides up, but we're seeing you, which is great. But if you want slides up, they're not appearing.
Okay. So that is.
I wish I could technically help you, but I have no idea what you need to do.
Okay. So let me just try and do this again. So apologies. I think with the, can you see the slides now?
Yes, perfect.
Okay, so apologies. I think the whole screen, I cannot move this between the slides.
Don't worry about it, that's fine.
Okay, so we had a series of escalating measures as we had our epidemic developing, and it was really the 17th of March, I think, the most or the strongest, the beginning of our stronger measures, with the closing of all schools and the daycare for under fives. And then on the 22nd of March, we sort of had an implementation of social distancing and a very much not a lockdown, but a real decrease in our public life. And that lasted until the 15th of April, when there were the first steps towards a reopening. On the 27th of April, the last measure that was introduced was that national masks were, or sort of, type of mask became obligatory on public transport and shops. And I'll talk, so these are essentially the measures from which we were talking, or which we're thinking about de-escalating. And then I wanted to say briefly something about the governance of public health in Germany to position the work of the Robert Koch Institute within this. So very important for us is that we are a federal system. So there's a federal Ministry of Health, but there are also Ministry of Health at state level who have responsibility for public health. In terms of the public health infrastructure, we as a Robert Koch Institute are the National Public Health Institute. We advise the government and we provide evidence. So in this epidemic, we've had a very central role in producing guidance, producing the evidence and strategies, but also for the medical and the public health community. So a lot around the strategies of how to test and so on. We also support the other structures within the federal system as they request assistance. So there are local public health offices and public health institutes in some of the federal states who may or may not come to us for guidance. And this was obviously very much the case during the outbreak. So this was a very large part, a very central part of our work during the epidemic so far, during our epidemic so far, and I imagine much the same in many of the sister institutes. And then I wanted to say just a word about the Center for International Health Protection, which is really focused on the international collaboration. So we began with support through laboratory training or technical cooperation on public health responses in low and middle income countries, and this followed a pattern of roughly until mid to end February. This was done in person, and then we switched remotely to webinars and different types of diagnostic support, for example, working closely with the WHO and so forth as travel restrictions came into place. We've also participated in a number of WHO missions, and one of the things I was keen to highlight in talking today, before talking a bit more about the exit measures, was to say that in this work we have really seen an incredible amount, an explosion of communication and collaboration. So while of course this has had a very severe impact on us as a global community, I do wanted to echo your words, Dr. Copeland, in saying this is an opportunity for the public health community in a way to bring our countries together. So this is a bit the situation in which we found ourselves until very recently, when we then started to think around considerations for de-escalation. And our first de-escalation happened on April 15th, with the bigger, sort of the greater decision to really start public life again on May the 6th. And the important thing, and here I come back to this federal structure in Germany, is that the decision was made at the cabinet level. So our chancellor has been very involved, but then, and there were some parameters set, including that all kids should have been to school before the summer holiday, but that a large number of the way in which these were translated was given, or that authority lies with the different states. So we are seeing a great divergence in how this is being implemented. At the point of this de-escalation decision, the federal and state governments agreed that local authorities would reinstate restrictions immediately if there was a rapid rise of infection in the regions seen again. So in terms of what we thought about when we thought about de- and re-escalation. So in Germany, we don't have a de-escalation or an exit strategy. Rather, this decision was taken, and now the states are translating this slightly differently, and some have indeed developed escalation strategies. And within the Robert Koch Institute, we have been advising or sort of providing some thoughts. And these are really the thoughts I wanted to share with you now. So we thought that really de-escalation should be at a point when there's a legitimate expectation that there will be no need to re-escalate at a regional or national level, ideally even at a district level, so that once you de-escalate, you try to have these large-scale measures as a society again. Central to that was the thought that there should be sufficient healthcare and public health capacity, so the ability to isolate, to test cases, to isolate cases where these are confirmed or suspected, and also to follow up where cases have occurred. So capacity of our public health sector at the local level is a central consideration in this. And of course, within that, sort of the idea that there's no uncontrollable community transmission. So very much guided by the idea that de-escalation should ideally only be implemented once at a national level. So what we want to avoid is that you de-escalate and re-escalate at that very high level in this very sort of disruptive way to society and the economy. And so one of the thoughts and recommendations I think that we felt was important was to say that re-escalation should be done as confined and as close to the local setting as possible, to really appreciate the quality of what you might see in terms of an outbreak, whether it's a specific, whether there's a large number of cases in a facility, say a healthcare facility, or whether it's one or two clusters, or indeed whether you think, oh, there's something going on in the community. Those seem to be qualitatively quite different things that require a local solution. So that was one thought. I also wanted to talk a little bit, and I wonder whether others share this sort of the idea of what's in a number. So the pitfalls, we wanted to try and avoid pitfalls of setting national numeric thresholds around. I think many countries might have also experienced a great attention on the rate of reproduction, the R, so media reporting this daily, or specific levels of incidence. At cabinet, it was actually there was a decision taking that where incidence goes above certain 35 or 50 per 100,000 in the population, there needed to be some measures taken, but we were quite cautious, having observed how the media concentrate and how the public concentrates on one specific indicator, and what the pitfalls of that might be. Another thing that we thought about was very much, so what we saw in the development of our epidemic as it moved through the population in a way, or as it developed over time, was that initially we had quite a large number of our infections occur in the younger population. So there were people returning from skiing holidays, for example. And then we saw this move through the demographic into the older population, and increasingly so also into care homes and such facilities. And we really felt that universal measures, the universal distancing measures, the sort of face masks and reduced contacts are important to shield those vulnerable groups, or what is seen as vulnerable populations. We felt from our experience that it is probably unrealistic to say you sort of shield that population by cutting them off from public life, rather to take the opposite approach and say we all need to take some measures to allow us as a society to move forward. And this was particularly sort of initially discussed in relation to our older population. So we then thought a bit more around 3 areas for assessment when you think about de-escalation. That was very much building on the WHO's work, where we thought around transmission dynamics, the severity of illness, and the impact on health services and beyond. Very much noticing that these were the sort of 3 indicators or areas of indicators that you need to set against public health objectives, against social acceptability, the economic and the wider social cost of the measures overall. So ultimately, I think we are very much aware, and I think at the Robert Koch Institute, we're very much aware that we could provide some ideas around those principles, but that it is a political decision about how society collectively wants to respond. And I think it's been, for me as an individual, it's been very interesting to see how different societies within one region, if I look at Europe, have adopted slightly different models. And I think we're all feeling our way forward in that respect. And I just wanted to speak a bit then, because I know we're focusing on that, about some of these areas of indicators. So around transmission, we had thought of the number of COVID tests performed per inhabitants per week. That could be an indicator. So this is not something that's set by the state, but we had thought of that. And we had also thought about how indicators needed to adapt over time. So you might set an indicator at this point in an epidemic where we are still seeing, so at the moment we're seeing between 800 to 1,000 new cases in the last week per day, 800 and 1,000 new cases a day. So you'd have to set an indicator somewhere, or a parameter somewhere that made it. But also to think around a test strategy. So one of the things for us, our strategy has been very much around obviously identifying cases, isolating confirmed and suspected cases, and tracing their contacts. And even though we've been relatively successful, I think, in terms of scaling up our testing capacity, or we've had a large network of laboratories working, even for us as a country of 80 million, it's very clear that testing capacity is very much a finite resource that comes at a cost. So those were some of the considerations we thought around testing. If you wanted to think around transmission, that you take that together with the effective reproduction number, the famous R, to give you an idea of the dynamic of how your epidemic is developing, and to consider that in relation to new cases. With R, so some of our, and I'll be curious to hear in the questions, so in our national debate, there has been a lot of attention on this, and potentially some confusion actually, because at what at what level we then thought, does it make sense to calculate an R and look at it? Because if you have very low numbers in a certain district, obviously if you get 1 or 2 extra cases, it goes up above 1 and so on. So we had thought in certain learning from our experience that it only makes sense to have this for a larger area of population, either at national or federal state level. And we also thought about the incidence, to consider a period of 7 or 14 days to have a bit of reliable per 100,000, and to consider thresholds at the district level that then indicate that you need to increase monitoring. And then this is really where our indicators have gone now, with this 50 per 100,000 over 7 days. And then just to say on impact, I will talk less about the severity. I can answer questions later, but I just wanted, on impact, we were thinking about 2 aspects. We were thinking about the health systems. So if we were thinking about the health systems capacity as the public health services, and obviously hospital capacity. And for us, there were 2 key considerations, really, to think about the capacity constraints of the local public health departments. So the ones who really need to do the contact tracing or the follow-up, who have that, what can they deal with? And the second one is obviously how, in terms of much more the hospital sectors, can you take care of your ill, and can you take care of your sick? So we thought of a ratio of free and occupied ICU beds as an indicator. So rather than thinking about this as a number again, we thought maybe one could think about what kind of percentage would tell you something. So if I don't know, 25 or 30% of our ICU beds are occupied in any given area by COVID patients, that would tell you something about where your epidemic was at, and how well your health system was coping. But with the hospital-based, I mean, ultimately you need to protect your hospital capacity, or that's one of the thoughts we had. But if you use the hospital as an indicator to tell you where you are in your epidemic, that seems quite dangerous, because we know there's this delay. By the time people are in hospital, your epidemic is obviously well underway. So those were some of the thoughts we had around these different indicators, and that we've been sort of sort of that informed our thinking, and that has informed the public debate, and that reflects a little bit the experience that we've had here in Germany. Again, they're just sort of thoughts for food for thought for our discussion. So thank you very much, and I'll hand back over to you. Thank you.
Jeff, you're on mute. Jeff, you're on mute.
Sorry. Thank you, Quentin. Again, quickly, we're delighted to have Dr. Frode Forland with us from the Norwegian Institute of Public Health. He's Specialist Director for Infectious Diseases and Global Health, and we're eager to hear information from Norway. So hand it over to Frode.
Yeah, are you able to see my screen?
Yes.
Is it full blown or is it just half blown?
It's 2/3 okay.
It's okay.
It's just that you have your individual slides visible in a panel on the left. If you can make it.
But it's okay. We can go from here. Eh?
Okay, that's fine.
So thank you very much for inviting me. Good morning, everybody, and good afternoon to those of you who have come to that stage of the day. Thank you for this opportunity to speak a bit about the Norwegian experiences we have, both in closing down the society and now opening up. So the outline will be a bit about the Institute of Public Health in Norway and its role in the national machinery, about updating on the situation with regard to lifting measures, and what about some of the concerns we have regarding lifting of the measures. And also a little bit on a process of rapidly reviewing the evidence that we have been doing in Norway, and maybe a little discussion at the end on other thoughts relating to learning points. Is my sound okay?
Yes, excellent.
That's good. So the mission of the Norwegian Institute of Public Health is actually to produce, summarize, and communicate knowledge to contribute to good public health work and also to good health and care services in the country. So we're also an institute for the health services, not only for public health functions. And in this way, the National Institute of Public Health contributes to better health in Norway and hopefully also globally, which is a part of also our mission to work and act globally where we have a national responsibility and capacity. We normally say that we are working within these three boxes about knowledge, about preparedness, and about infrastructure. And then we've set up a number of strategic initiatives under those headlines, which I won't go into in detail. And we are serving primarily, I would say, the national authorities, municipalities, the population at large, and also the health care and health services. And you also see there are other names there on the list that we are working with and interacting with, but those are our main stakeholders in the situation. And the key areas of work, as I told you, knowledge, in that sense, we are doing research. I think we are producing like 800 peer-reviewed papers per year. We're doing analysis of data. We are keeping a number of the surveillance systems for healthcare and also for public health, both related to infectious diseases and non-infectious diseases. We are also the hub of the Norwegian HTA agency or the Cochrane agency, and doing a number of literature reviews and systematic reviews, writing reports, news bulletins, guidelines, and handbooks. On the preparedness level, we are having all these ongoing activities where the preparedness lab for a number of, I think, 30 bacteria and viruses. And we're having also an infection disease control officer online 24/7. We're having communication staff online, and we're the national focal point for the international health regulations. Related to infrastructure, we are also holding this surveillance systems for infectious diseases, all the disease registries, and also for non-infectious diseases. We, as I mentioned, are also a reference lab for like 30 bacteria and viruses. We're having a biobank and registries. And all this ends up in recommendations, advice, information, publications, and so on. So that's a bit of the role. And the role related to being now in this epidemic is that we are a the central advisor on infectious diseases to the government. In peacetime, we normally do this on our own, but on the 12th of March this year, then the government took over the responsibility, and we are reporting to them and giving them advice. On a normal peacetime, we are also giving the advice ourselves, and that somehow constitutes the guidance for the public and for the healthcare services. Just a short reminder of this disease pyramid that I'm sure many of you are familiar with. But this is to say that we always know a little bit on top here, but there are still a number of red spots below this, on the lower level of this epidemic that we don't know much about. How many are exposed? How many are infected without having symptoms? And how many have had symptoms without reporting them? And when you come further up, we know those people who have been in touch with their GPs, that's a high number. And we know those with positive tests, those who have been hospitalized or are in intensive care, or finally those who lost their lives. And these are all reported through different sets of data. And what we have been doing now is trying also to combine a number of these data sources, where we have the national registries for deaths for COVID-19, the registries for intensive care, patient national registry, and all that has been collected into a new registry called Beredt, which is the Norwegian word for preparedness. And still, we are now trying also to have a better view on how many are these gray numbers, how many are infected without us knowing it or them knowing it, and how many have been going through the infection. So we are setting up national surveillance, national surveys to try and have an overview both of the infection prevalence and on the prevalence of seroprevalence, those who have gone through the infection. This is the epidemic curve from Norway from yesterday, and you see we had this abrupt rise of cases in mid-March, and those were in Norway as well, people coming home from their winter holidays in Italy and Austria, bringing it from, as in Germany, from young people who had been out sporting to the nursing homes where they came home and were working, some of these people. And we see now that the curve has flattened from like beginning of April and going steadily down until we are now at a very low level with like 18 cases only reported, as far as I remember from yesterday. So that means the epidemic has somehow been controlled by those measures that were taken. And I'll come a little bit back to that. We've tested something like 200,000 cases now, and the number of positive tests are like displayed on the black curve here, going down, even though the numbers of tests have been a bit steady. And now we have a test capacity, which is large enough to be able to test everybody who we think we need to test. So in that sense, that has been built up gradually, and we encourage people also with any symptoms to be tested. And that's part of the strategy when we are opening up again society, that we can test more broadly. And up to now, testing has been restricted to those with symptoms or those in specific risk groups or being admitted to hospitals. So the strategy so far has been to try and preserve health, avoid societal disruption, and also protect economy, an overall strategy. And from March 12th, I told you, there was this, what we in Norwegian have called the knockdown strategy. We wanted to knock down the spread. They didn't use the word contain, but it's more or less in the same direction of the word. And then massive measures were started across the society. We closed the schools, the kindergartens, and imposed people to stay at home for work and all those things that you know from other societies as well. But still, we kept restaurants open and shops open and advised people to keep distance. All the public transport has been opened, and people have been allowed to go out. Even if they were in quarantine, they were allowed to go out, but not to get in touch with other people. And the purpose here was, of course, to prevent overburdening of the health services and also to gain time to prepare at all levels of the society, in the healthcare service and other parts of society, for what we expected to be a bigger wave to come. And then we saw that these measures altogether were pretty effective to curb the epidemic. And from the 20th of April, we started lifting measures again. And then the strategy from now on has been called a control strategy. We want to control the spread and to keep it on a low level with a gradual de-escalation and controlled reopening of society. including then active testing, contact tracing, and isolation and quarantine of each and every case. And still to be prepared for a possible re-escalation of the spread, hopefully at the local level, but also to be prepared on a national level if need be. So the reopening strategy has been like a stepwise and controlled approach from April to August. It's now made a plan the whole way up to August. And the first thing has been to care for the kids, to try and get people back to kindergartens and school. And from this Monday this week, all primary schools are fully open again. It started with kindergartens, then it was 1 week with also the low grade schools, and from this week, full schools open. And then to get people back to work, but not to say that they should stop working from home. If they can work from home, that is still the advice for most people. And for those who especially need the public transport, they should try and work from home if possible. And then to keep the social distancing measures and hygiene measures, protect the vulnerable. So specific measures have been taken now towards hospitals and also especially among the homes for elderly. And then comes to reopen leisure and fun. We've started reopening sports clubs and these things, but that comes a bit lower down on the level of the priority. And there has been what we can call like a whole of society responsibility here, or a response where everybody have been asked to do their part and to work together to achieve these ambitions and these goals. And our minister said, we are now going from having a critical awareness on this to get it into our daily routines, the way of living with this, because this will be something we have to live with for a long while, a year or two or something like that. And then at the end also to mention that we have been also discussing how we can perform global solidarity during this outbreak. Then I think it's fine to remind about this man who has had a tough time, sitting there every day with his press conferences and with some wrinkles in his forehead. And I think the IHR is again an international regulation that we have to remind about, with its purpose to prevent, control, and respond to international spread of disease, and also to avoid unnecessary interference with travel and trade. And I think when he first issued the the public health event of international concern, he was writing to the global community that we should all remember Article 44 of the IHR, which is saying something about every country is being obliged also to support each other in identification of the source of the virus, also for financial and professional support across countries and across rich and lower middle income countries. And also to state parties in this fake, it was written that related to preparedness, we should strengthen preparedness for health emergencies, build resilient health systems, incorporating lessons learned during different stages of the pandemic and sharing experiences with other countries, which is actually what we are doing now. So thank you to IANPHI for taking this initiative. And I think also to work with multi-sectoral partners has been shown to be extremely important in this case. During the epidemic, I've been on a number of press conferences and I've been standing there beside different ministers from different ministries every day. It's been Ministry of Transport, Ministry of Education, Ministry of Agriculture, Ministry of Culture, and Ministry of Health always, Ministry of Preparedness, Ministry of Justice. So it's really showing that this comes to a one health situation where we have to work all sectors of society. Then some few words about this, about getting information when there is a huge uncertainty. And I think this is what we are having now. We're having an epidemic which haven't been there before, where we didn't know much at the beginning, and we have a huge area of uncertainty that needs to be covered by good studies and by good knowledge and good research. And there is this area that we want to increase, the area of knowledge. And we've had short time to make a lot of risk assessment in many countries. I think it's extremely important also to use a systematic approach when addressing the evidence. And since we're having also this HTI environment in our institute, we've been making a number of also short evidence summaries and reviews that I can show you. For instance, in the beginning, when I saw this picture, I thought it was a bit funny. This was the President Moon from South Korea having his cabinet with all these people with his face masks. And to Norwegians, this appears like something we just see from the East and we laugh a bit of it. Now we've seen it's even become compulsory in Germany and it's approaching north of Europe. Still, I would say the evidence for this is extremely weak and dubious, but at least it's a question of concern also to see what measures can we take, both for the precautionary principle and also for really understanding that it helps. And what we have made is a map over all really newly published studies on COVID-19, which you can flick up on the net, where we are sorting all the evidence on etiology, on prognosis, on causes of disease, and on epidemiology, and so on, where we keep an eye and judge the evidence and route it for you, so that's easier to find. And what we have done ourselves is also to make memos and short updated summaries of issues like the spread of disease among children, aerosol generating procedures, about the contact transmission, and so on and so forth. So this is publicly to be shared, and we actually have a small paper coming in Eurosurveillance hopefully this week on this, where you can also find links to this evidence. We know that the same has been done in other countries, in France and in Ireland and other places, and also the Cochrane collaboration has been involved in doing this, which is, I think, very useful work. So these are just the website where you find them. And we've seen also that this has become like an important international gathering of the central leaders of the world. So this is just from a chronicle those guys wrote together in the Norwegian newspaper, I'm sure in all the other newspapers as well, saying that we work together to try and make the world safe and healthy again. And in this chronicle, they were I'm citing this, but what we all have in common is that none of us can plan for, be sure of the future of this pandemic. This means that we are all part of this. None of us are immune to the pandemic, and none of us can beat the virus alone. We will not be safe until everyone is safe in all the world's cities, regions, and countries. In our interconnected world, the global health system is as strong as the weakest link. We must protect each other in order to protect ourselves. I think those are very wise words. And I think we hopefully won't have this big wave at the autumn that many people are talking about. This is a slide from ECDC showing potential scenarios for the future. And I think in Norway, we are hoping for the last one here on the picture. We've had a curve already going high up, and now we are preparing for these minor bumps on the way. And we will try and stop them as soon as we can recognize them by intensive testing, tracing, and quarantining and isolation. So at the same time as we shall prepare also for a more worst case scenario. So finally, some learning points. I think the principles of preparedness, they remain. We should try and deal with this, where those who are responsible normally should keep on the responsibility as close to the source as possible to handle it in a similar way as we normally do, and with an obligation of coordination across and collaboration with sectors. So this pandemic has shown more than anything that it's about the whole of the healthcare. It's about the whole of the society and also a whole of the world at the same time. And it means to me that it's also a cry and really a shout out to say that universal health coverage is what is most needed also for the preparedness purposes of the world. Many people have talked about disruptive technologies changing the society. I think this has been a disruptive event, a public health event of international deep concern that has the opportunity to change the society for the future. And I think it will. So hopefully we can learn to live together in a globalized world without destroying the globe further in the future. Thank you very much.
Thank you very much, Frode. Excellent, lots of information and a wonderful view from close up and a wonderful view, much larger and a global view with elements and learning points that we can all benefit from. So appreciate it. Thank you very much. For those of you who might not have been able to see your screen earlier, the gentleman who was under great pressure and doing highly responsible work, and we all see as a close colleague, Dr. Tedros was pictured in that picture with, as Frode said, with lines in his forehead, which is good because we've all got lines in our forehead these days. So let's move right into questions and answers. And I'll try not to try to place the emphasis on these questions coming from the participants. One point is that there's a lot of interest in contact tracing and how that's gone in both Germany and in Norway. has it been difficult? Who have you employed in doing the contact tracing? Did it involve hiring up? Do you consider this a very expensive undertaking or not? We'd like to hear from both of you on that if possible.
Shall I?
Sure, please.
Briefly, so yeah, I mean, contact tracing obviously has been very important, has remained an important part throughout. And obviously now with de-escalation, as I think also Frode was saying, will be very important. In Germany, we have a key aspect for us has been to strengthen the public health infrastructure at the local level. And as part of that, so there were various, a bit of a financial package for them, but we've also recruited what we call containment scouts, which are sort of medical students to a certain level who had some qualification to a certain level, but who have taken some time out and who will support this local level infrastructure specifically in the contact tracing. So that has been a key measure. And I think, I mean, I don't know about the exact cost, but I think this is obviously a huge undertaking, but I think this will be an essential one. And then the next point is obviously we are still in the development of an app that we hope, a software solution. I know many countries are developing apps. This has not been launched yet, so we haven't seen the introduction of that yet. But there are obviously some hopes and expectations that this type of app will also assist further with contact tracing. Thank you.
Johanna, would that app also be one that involved cell phones? Would that be and communication between electronic networks?
Yes, I think there have been several changes over the time that it has been developed, but the basis of it, I think, is that people use their cell phones to be able to trace back who they had exposure to at which time. And I think already in the opening of society and shops and so on, I would imagine it will become more common for people to ask for contact details to enter a shop or to visit a place, so that in case you know you have had a known case, there is a way of tracing that back.
I think I can follow up on that. Is that all right, Jeff?
Please, brother.
Yeah, we are still working on getting an app working. It's in a test phase in 3 big municipalities, and it shows quite difficult, but still with a hope for the future that it can last for a year. So this is also getting hold of people who have been in less than 2 meters distance for more than 15 minutes with somebody. So that's been like, and using Bluetooth and GPS as the means of understanding how they've been moving around. And it also gives information about the movements of people in society, which can be helpful also for understanding the development of the disease. Otherwise, the work for contact tracing is done by the municipalities in Norway, and there is a municipal public health officer in all 350 municipalities with staff that are trained to do this for any diseases, any time of the year. And they've really been put on stress and also been put, I think, in priority, certainly in the municipalities in a different way than before. And I think having these local systems working is extremely important in this case. For the future, that will be the only way we can do this. And it's also funny to see Norway is now actually adopting the district health information system, which has been developed for and used in many low-income countries and never taken to Norway before. Now we would like to try and use it for tracing contacts during COVID with a tracker that has been developed in Sri Lanka.
Good, thank you. Thank you both. I'd also like to involve Quentin from the Public Health Network out from Wales, but also Public Health Europe Network. Quentin, do you have any observations or comments to make on what's been said?
Thank you, Jeff. I think what strikes me, and I've joined a number of these webinars over the last few weeks, is we all are doing very similar things, but we're doing them sometimes in different ways, and that more often than not reflects the unique arrangements in our own public health and healthcare systems, or perhaps even cultural differences between countries. I think it's recognised that the UK has now the dubious distinction of being the country in Europe with the largest number of deaths associated with COVID-19. We're not proud of that, and it's a source of considerable political and public debate at the moment. We've been in quite considerable restrictions. We've called it lockdown since has its own jurisdiction over health. And we are now beginning to see some divergence between the different countries. So although they are all doing elements of contact tracing, sampling and testing, and surveillance, certainly the approaches to contact tracing are beginning to diverge, and some of the approaches to testing as well. And that presents us with challenges because we have internal borders or boundaries between those countries, and public messaging through our media doesn't recognize those boundaries. And we in Wales, for example, have a more restrictive set of limitations than England. England are beginning to open up a bit more than us, and we're already seeing some challenges associated with that. I have to say I'm deeply impressed by the ability of other countries, and we struggled a bit with this, I would say, in the UK, the ability of some other countries to mobilize their resources as quickly as they have. I'm really very impressed. In part, I think that reflects the slight differences in the infrastructure that existed beforehand. I've had the pleasure of talking to Lothar at the Robert Koch Institute in recent weeks, and clearly having a very large laboratory network that could be redirected quite early to serological testing for COVID gave you a considerable advantage, and we had to mobilize laboratories. That took a while, and our testing numbers nowhere near quite match those that other countries have done. So I'm really impressed by the responses of other countries. I won't say any more, and just say on behalf of the European Regional Network, a thank you to Jeff for enabling this discussion to happen.
Thank you. Thanks very much, and appreciate your participation. There's a number of questions around the area of schools and children, the role they play, how one will monitor what goes on in schools to know when to back off and whether social distancing is working. So Johanna and Frode, if you could address that a bit and how you're dealing with the schools in particular.
Yeah, well, we've sorted out when people have started again, both in kindergarten and schools, they've started in minor groups, and a new word has suddenly appeared in the Norwegian school system, cohort. Nobody had heard about it before. So that actually people are in groups where they're also playing together and are in the classrooms together and not mingling with everybody else. So if there is somebody who gets ill, and everybody who has a flu or a kind of symptom of any upper respiratory infection are supposed to stay home and be tested. And if they show to be positive, then you can actually close down the class and not the whole school. So that's the idea here. And the same with kindergartens. And still, people are advised only also to stay together in the private, only 20 people as a maximum. And in society as such, up to 50 people now is allowed on a public arrangement if you have names of everybody and at least 1 meter distance between them.
Yeah, if I can follow up from that. So we've been watching with very great interest your work on the schools and the young children in kindergarten. In Germany, we have been slower with the return. We are starting now. Again, this now varies between the different states, but it's from this week that students are beginning to return. I think also in most of the states it is in we call it shifts, or so there's also smaller groups and the idea of a cohort. And I really like the example you gave with the class. So what we were also thinking when we were thinking about de-escalation and re-escalation was to precisely think that you keep groups of people together in a way that you can maybe don't need to close the whole school, but you can just then deal with it on a classroom level. So we are still waiting to see how this will affect us, and this has been certainly in our society one of the most debated issues and sort of topics where we have looked. And I think also very interesting, and thank you for allowing this platform for sharing, because I know that the Scandinavians or countries have taken quite different approaches, and I think it'll be continue to be interesting to see how the evidence develops in this regard.
We have followed the magic R as well after we've opened up, and we've seen it's still stable on approximately 0.5, the effective R.
Excellent. Maybe you could each say a little bit more about maybe giving advice to others, particularly in the area of, as you've indicated, numbers. What are the numbers that count? And how important is it to get those numbers at whatever stage you're in? And so, but each of you have addressed it in part in your talk, but maybe if you were to give advice to others, what would you say? When testing is to be done, what's your target group? And what determines when you move groups or expand it or contract it? What are your indicators for doing that?
You start.
Okay, I would say something. So in terms of the numbers, I think for us the key lesson has been that it's not one indicator that will tell you everything. And I think this has been the important thing to communicate. And I think the challenge for the politicians also to communicate to society. So we have also focused on the famous R, and ours went below 1, and then at the beginning of this week it was above 1 for a short period of time, and there was a lot of discussion, but it's back down below 1 now. So that certainly has been an important indicator for us. I think we have also very closely looked at the number of new cases each day and the distribution of that, precisely because of the these local public health officers at the municipality, we call them Landkreis level, who really, I think, are the key to be able to catch when things happen again now, as we start to live with this, and to see that they are not overwhelmed. So this has been also important. In terms of testing, again, as I was trying in the reflections on the slide to sort of say some of the thoughts why we thought threshold values can be difficult to set, especially in a system where you have national level, federal level, and then the municipal level. Our testing strategy has been continuously adjusted. It's been a central element, and I think at the moment we are also, so it's been adjusted as our capacity to test has expanded, but at the same time, obviously, also our epidemic developed very dynamically. So at the moment, we are able to test anyone who is symptomatic. So anyone who has even mild symptoms should be tested, and then people now going to old people's homes and those vulnerable populations also to be tested, very similar, I think, to Norway. And I think this will continue to be fine-tuned. So it's certainly an essential part of our strategy. I wonder whether, but this is just my thoughts, is whether with these values and numbers, it's very different if you have a comparatively small population to if you have a comparatively large population with a decentralized governance structure. I think they're threshold values to me seem a tricky business.
But we see it actually the same. There are huge differences also between Oslo and other parts of our country. So within countries also there are huge, I think, differences in many places. We have been discussing the last few days also about thresholds. Somebody wants thresholds. We think it's difficult to find a right number for any kind of threshold here. But I think what you mentioned also about the capacity of the intensive care units, the beds there will be one possible way of evaluating where we are. And we can also have a test capacity up to 300,000 tests per week, which is more than needed as it looks now. And other relevant numbers, as I mentioned, 50 now in gatherings, up to 200 after the 15th of June, which is the proposed number. And then we have reduced the days of quarantine from 14 days to 10 days. And then the testing also becomes much easier as we are moving into probably testing only by using saliva, instead of having health personnel doing the swabs of the throat or the nose. People can just spit into the tube and then send it.
Good, thank you. I apologize to the other attendees at this event that I'm not giving names and addresses. What I'm trying to do is lump questions into groupings so we can get more of a response to all of your points. For example, there's interest in modeling. How much of each of you depended on modeling, used it, and how are you looking at it as a future help in the future?
I would say modeling has become the sports of everybody on media, social media, and also I think our own modelers, they have been given extremely much weight, I think maybe too much. And I think it's extremely important to have people with knowledge of the field of public health, not only with mathematics and how you can put numbers into advanced figures and equations. So I'm a bit afraid that this is also hiding and blurring information sometimes and giving this magic feeling that we know everything when we see a number. We don't know anything more than we did before we put those figures into the equation. So I think we should have a bit of caution to those models.
Thank you. Johanna?
So we have a very small team, or really very small team here who has been doing the nowcasting, who has been doing our predictions and our calculations of that. I think also this has been a bit the epidemic of the modelers, and I think it's very useful in terms of, it has been very useful and obviously very influential in terms of giving politicians guidance in decisions that have been very difficult because they've had to weigh the potential impacts of these societal measures, health measures versus other societal impacts in the absence of great knowledge about the virus itself. My feeling is really, this was one of the points I maybe wanted to make, in addition actually to greeting you from Lothar Wieler, so I apologize, I should have started with that. But one of the big things for me is really how far we've come in the last 3 to 4 months. I really feel we now have a much greater understanding of situations where risk is high. And I think as we learn more about the virus and the way it behaves and so on, so this may shift again a bit the sort of skill sets that are of great value. It's a bit of a fudge of an answer, but I feel sort of one of the big things I feel is the learning that has happened over the last 5 months, if I look back. Thank you.
Thank you. A quick question aimed, I think, at Frode. Norway has reduced its quarantine from 14 to 10 days. Is that correct? And could you explain the rationale?
Yeah, we've been calculating how many days you need to quarantine people to find one, to avoid one being infected by another. And it's a huge number of days, and it's a huge societal cost of doing that. So we've just calculated on these numbers and found that almost everybody will be caught within a 10 days period. And with more active testing, it can also be a safe enough way of doing this. So this is a way of rationalizing and finding a way of doing this according to the best evidence we now have around the time lag it takes before and the period before the disease breaks out. So it's a bit the same we've tried to do also with how many people need to wear masks, the number needed to mask to prevent one case, and that's a huge number. If it's at all possible. That's like a little bit of thinking from the evidence-based way of understanding how we can figure out these numbers. Thank you.
Thank you. What symptoms are being used to trigger testing? Is it just fever and cough, or more broadly? And do you see the criteria or your definition of for when someone does need testing to be shifting over the course of the outbreak as it reaches different stages? Johanna, could you start with that?
So I think this has continuously developed. So the AKR has a sort of in German we call it a Steckbrief of the virus, which describes the clinical symptoms and provides guidance both to the sort of medical public in what to watch out for, but also now to the more general public as information. So this has and it has developed. So I think it now includes the loss of sense of smell and taste, as well as I think the other symptoms that have become apparent around skin. And I think this is something that we continuously update different colleagues within the RKI. So I'm less, it's less my area, but I know that this has very much developed, and we also review the evidence and then see at which point that guidance changes.
Yeah, it's much the same in Norway. We had rather strict indications for testing when there was a scarcity of tests, but that has become like now we have enough tests now, so it's opened up, and we want to test as many as possible related to situation where they work in healthcare setting with any mild symptoms. They are free to come and test. So that's opened up, and it's also more like using testing for a precautionary principle in some situations, not only to diagnose people. And we've seen, even though we've used strict indications with upper respiratory clear symptoms, 95% of those who have been tested with symptoms have been negative to COVID-19. So in that sense, also, it has been a lot of other things going on. Now we see much less because we are approaching spring, even though it was snowing yesterday. But then also the number of other respiratory infections goes down.
One quick last question for both of you. In the course of this pandemic, many of the countries on this call and presenting have seen fit to close some borders, both between countries, but also within a country, as in experience in China and Wuhan and various provinces. What do you two see as the value in closing borders? Is it useful at some point in the process and detrimental in others? What's your take on it? Frode, you want to start with that?
Yeah, we've even seen municipalities up north closing Norwegians from coming from the south to the north. So there has been restrictions within the local municipal level, which they are kind of allowed to according to the Norwegian disease law. But this was also infectious disease law. This was considered a big problem for people who are working across municipalities' borders. And of course, we see the same when it comes to the borders of Sweden. And of course, there is a logic to closing a border if there's a huge difference in the spread from one side to another of a country. And as this is moving and becoming more like the normal situation in different countries, the effect of border closure will reduce. We have a challenge now related to Sweden, and still there is a obligatory quarantine of anybody coming to Norway to be from outside of the country to be 14 days in quarantine before you're allowed. That means now 10 days before you're allowed out into society.
Thank you. Final comment,
Yeah, so
Johanna?
we also have an obligatory quarantine of 14 days still in place. I think this is a very difficult area for de-escalation. And I think it's one where exactly we as a global community will have to work together very much, and beyond the national public health institutes. I really think this is a job for politicians to work together in Europe, the European Commission, for example, and beyond. So I think this is a sensitive area, and but hopefully, in our region, for example, the epidemics are reducing so much that there will be less of of a barrier to this discussion. But I suspect that this will be something that we'll be talking about for quite a while in the public health domain, the lessons from this. Thank you.
Thank you. Thank you both, Frode and Johanna, and Quentin's input to a wonderful panel discussion. Lots of unanswered questions for all of us. I think that the graph that was shown of large levels of uncertainty, getting to more moderate levels of uncertainty, and compressing finally into a real pithy concentration of levels of uncertainty is where we all are or not. Maybe what we need to worry about is that the big wide part at the beginning is probably still big and wide of uncertainty. As we uncover new levels, we only become a little less certain about whether we were right a week or two before. But we're in this together, and one of the great, I think, areas of solace and strength in this is that we do it together. So this is a good example. It's an honor to have you folks present and describe your thoughtful and excellent programs. And we look forward to more of these seminars where we learn from each other and share ideas. I apologize to everyone who didn't get their exact question asked on screen, but we did have limited time and I tried to group them as much as possible. So thank you all. Thank everyone who's listened, and good health to you, all of you and your colleagues and your citizenry.
Thank you so much, everybody. Goodbye.
Thank you very much.
Bye-bye.